Thank you all for joining us this afternoon. This is Jane Jembrin from Stratus Health, and today we're going to be focusing on improving mental health through community partnerships. We have two different speakers who are going to be telling their story this afternoon. Shelly Zuzek, who is the Director of Integrated Care and Contracts from Vail Place, and Jan Carr-Herseth, who is the Director of Behavioral Health from LifeCare Medical. Let's advance the slide. And just to give you a little bit of background, I'm assuming quite a few of you are familiar with this initiative, but just want to give a little background about what we, the context for this work. So the Center for Medicare and Medicaid Services, or CMS as we fondly call it, has created this behavioral health initiative, and we are working with both primary care clinics and inpatient psychiatric facilities to address behavioral health needs. Again. So specifically, this initiative was started last year. We're going to be running through 2019 to address issues in the lack of access to behavioral health in the Medicare population. You may hear us say from time to time the Lake Superior Quality Improvement Network. Stratus Health is the Minnesota arm of the Lake Superior Quality Improvement Network, or LSQIN. We work quite closely with our colleagues in both Wisconsin through MedStar and MPRO in Michigan, and we're working collaboratively. And today's webinar is an offering for the LSQIN across the 30 states. Collectively, we have about 600 primary care clinics we're working with and about 15 different inpatient psychiatric facilities that are working on this initiative. The primary clinics have been implementing processes to ensure that patients are assessed for depression and alcohol misuse. And as a result of the screening, some clinics have developed protocols for positive screens. This includes both mild depression with management in the clinic, as well as helping patients with more acute or urgent needs. And the inpatient psychiatric facilities are improving transitions and coordination of services in the process of reducing readmissions. So today's presentation is really taking off from that with the understanding that frequently when patients who have urgent needs present in the clinic, that there is difficulty knowing how we can best serve those patients. So we've heard from several of the providers that we've worked with about how do we better serve those patients' needs. And one of the ways that we wanted to talk about today is through the reaching out and creating some community partnerships that we may better be able to serve patient needs. So what follows is going to be two different approaches. Both of these two programs are similar in that they have formed collaborative relationships with partners that may be somewhat unusual. The paramedics or jail staff, it's really looking beyond the typical healthcare providers to see if there isn't a way that we can work better collaboratively. Shelly Zuzek is going to go first, and she's going to talk about the work both at Vail Place and how they've worked with North Memorial and others within their collaborative. And then we'll transition to Jan, who is representing the work that happened at Roseau and some of the partnerships that they formed there. And then we'll have some discussion going on from there. So I'm going to pass it over to Shelly and have her start with the experience that is part of work that's happening in the metropolitan area through Vail Place, North Memorial, the University of Minnesota, and others. Shelly, take it away.
Thank you, Jane. Good afternoon, everyone. As Jane said, I'm Shelly, and I have worked for Vail Place in a variety of roles for about 20 years, all told. Vail Place is a mission-driven program that focuses on a variety of services that are person-centered and recovery-focused, community-based mental health services for adults who have serious and persistent or serious mental illnesses. Many of the individuals that we work with have experienced homelessness, chronic health issues, substance use disorders, trauma, etc. We are a certified clubhouse, and which is I could probably do a whole presentation on that. So if you're interested, you can certainly Google the clubhouse model. But it's a program that provides kind of on-site day interactions with members with serious mental illnesses, and through that process, they have an opportunity to access employment, housing, social opportunities, education supports, and that sort of thing. So why can't we ignore mental health? Mental illness is one of the most common causes of disability. Over 18% of adults experience mental illness, or about 1 in 5. Typical illnesses are depression, anxiety, panic disorder, and about 10 million suffer debilitating mental illness, or approximately 1 in 25. Adults living in the United States with mental illness die an average of 25 years earlier than others, and that's largely due to untreated medical conditions. And that's a status from NAMI. When people experience mental illnesses or other substance use disorders, they have not only those issues, but, as this slide shows, there's just a variety of things that kind of layer on top of the mental illness, making it even more difficult to manage these illnesses in the healthcare setting. And so what we can offer is a way to address these disparities in the community and in mobile-based services. I wanted to share a statistic that 5% of the population spends 50% of the healthcare dollars. I'm sure that's not news to anyone. But there's a blog post by Ezra Klein from the Washington Post that I'd like to read that really helps demonstrate the need for these community-based services and how we can work together. The problem with the 5% is not simply that they're extremely sick. It's that they're extremely hard to help. These people aren't just ill. They're poor. They have mental health problems. They're dependent on wheelchairs. They have dementia or brain damage. They live in unsafe homes. They don't have cars. They're agoraphobic. They're worn down by chronic pain. They're locked into bad habits and used to bad environments. Our healthcare system can deal with the very sick. Our healthcare system is arguably the best in the world at dealing with the very sick. What we're bad at is dealing with everything that happens outside the hospital, all the things that keep making people sick. And so long as those other things go unfixed, these people keep getting sick. Again, these partnerships that we're able to address or to create and address these disparities really can have an impact on people's health and well-being. As I mentioned earlier, Vail Place has 3 kind of main areas of service. We have our clubhouse model that I briefly introduced. We have a very large targeted case management program for adults who have serious and persistent mental illnesses. And we have a care navigation and behavioral health home services, which kind of fall under our integrated care umbrella. Vail Place is really committed to expanding our reach to share what we offer to individuals who are experiencing mental illness. We really look at what's the right mix of the services in collaboration with the healthcare delivery system. We can change thinking from chronic illness to chronic wellness, and we help people strive through this through our continuum of care and empowering others to care for themselves. As you can see by this slide, there is a variety of things that we can pick up where healthcare systems leave off. We can't do what we do without healthcare systems, and I think healthcare systems really need us to manage those things that happen outside the walls of the healthcare system. So partnering with behavioral health providers. There are some main things that that I wanted to touch on, and one is that it's so important to connect with the partners and develop relationships. This takes multiple conversations. And when you're starting these partnerships, make sure that you're including a variety of people, including the leadership, technology such as EMRs, compliance, legal departments, and to make sure that you're looping in people as needed. It's important to start talking about a service agreement or a contract describing the activities of the partners so that everybody kind of knows who's doing what. And then the last two things that I would add is be patient and be tenacious. These things take years to develop sometimes. Okay, start. So I wanted to talk about a little bit about how we were able to move our partnership forward. And one of the we had developed an initial relationship with North Memorial Health and had been in initial conversations about how do we improve the health of this population, people with serious mental illnesses. And we became aware of a grant opportunity, so we applied along with support from North Memorial for the State Innovation Model Grant that was available through Minnesota. There were 13 states across the U.S. who received these State Innovation Model funds, and through the process there were a variety of drivers of areas that they hoped to improve with health in the healthcare system. One of the things that they wanted to create was communities for health, and that was the grant that we received, and we then developed our Total Care Collaborative. A focus of the population, again, on individuals with serious mental illness and comorbid health conditions. The partners that we worked with were North Memorial Health. They were our ACO, Accountable Care Organization partner, which was a requirement of the grant. Vail Place was a nonprofit community-based mental health program. University of Minnesota Clinic, Broadway Family Medicine Clinic, which is an urban clinic, and they have a large Medicaid population and see a lot of individuals with many social determinants of health. And Portico Health Net, they're a health literacy organization and insurance focused on helping individuals acquire and keep their insurance. Through our Total Care Collaborative, we created 3 different models to help address health inequities and the triple aim. The first that we developed was the rapid access to case management, and I'll share a little bit more on that as we go along. Care navigation and our behavioral health program. And also we created a cross-sector interdisciplinary team for what we call our rising risk group. So individuals who may be at risk of becoming the users of costly healthcare activities such as the emergency department or repeated hospitalizations. And so the goal for that cross-sector group is to prevent high utilization, as I had mentioned, and make referrals to community and mobile-based services like case management, community parametrics, etc. So North Memorial is our Total Care Collaborative ACO, as I mentioned. They're a metro-based hospital system, and they have quite a few primary care clinics, and they have been healthcare home certified since 2012. They participate in the Integrated Health Partnership Program, or the IHP program, and that program focuses on the Medicaid population that's connected to their system, and the Medicare, and they have a Medicare shared savings program as well. And through these really important connections, they really recognize the need for collaboration with community partners to help manage the IHP population. We were really fortunate that North Memorial was very invested and engaged in this project. They provided aspects which we really could not have accomplished without them. They helped provide us with partnership and leadership and utilization data. They were able to work with us so that we would have some access to their Epic system, so we could share some patient information so that we could make sure that we were providing the best care possible. The data analytics, the hospital leadership, and just the connections to the clinics that we were partnering with on this initiative, and the care coordination efforts as well. So as I mentioned, North Memorial Health is an integrated health, it participates in the Integrated Health Partnership. They were one of the pioneers in 2013 and one of the first 6 systems that were certified as an IHP. And they're responsible for the total cost of care of their Medicaid population, which is about 30,000 lives. There was a new RFP that came out just this year with an emphasis on community partnership in the IFP, the RFP for the IHP. That's a tongue twister. And we were excited that after all of our work, Vail Place was identified in the proposal as a partner of North Memorial Health in managing their IHP population. Our goal is to impact the population overall with, again, that focus on individuals with serious and persistent mental illness. So our ACH, or our Total Care Collaborative, the partners bring together diverse settings such as clinical, hospital, emergency department, social worker, or social services, as well as backgrounds. We've had a variety of the individuals listed in this slide, such as the social workers and the care navigators, community paramedics. And our initial goals with the Total Care Collaborative was to, improve transitions of care in a variety of situations, to obviously reduce unnecessary ED visits and hospitalizations, to ensure continued access and connection to primary care and wellness, and to expand partnerships and build relationships, and to improve workflow and communication. This slide is a visual of our Total Care Collaborative as we were getting going, and as you can see, the patient or the individual is in the center of the slide, and around it are the variety of partners and services, with some of the kind of off onto the side are some of the additional services that we were able to kind of start building some relationships with, such as, we've expanded and been in conversations with community dental and Claire Housing and a variety of other partners. So we want to make sure that people are aware of us and what we're doing so that we can, again, wrap the right services around people at the right time. So now I'm going to talk about our rapid access to case management. And this was our initial, I think of our Total Care Collaborative as having 3 arms of model. And our rapid access to case management was the initial one that we focused on. Again, it was to improve transitions of care. When individuals are referred for case management from the hospital through the county system, it can take sometimes weeks to even longer for a case manager to get assigned and connect with that person. If they're already discharged, the availability to connect with that person dramatically decreases. The population that we see in this community often experience homelessness. They may not have phones, and so if our ability to get in and make that connection with the individual and engage with them in the hospital was huge. We had to design processes to improve access and wait time, and it involved conversations with the inpatient unit so that we could say, wait a minute, we're getting things too late. How can we get certain things sooner so that we can get clearance from the county to move forward? It's been a great collaborative effort, and at one of the care team meetings that we had, one of the social workers said that we are one big team, and we really now have hope for our client after discharge because they knew somebody was already there and connected with the person. So rapid access to case management, our initial cohort demonstrated the need to partner and work differently. We found about 50% have housing insecurity, frequent use of the emergency department, lots of trauma, substance use, and low socioeconomic status, and many of them are on medical assistance or Medicaid. So we were able to identify that by partnering differently, we can have a positive impact on people and the metrics and outcomes. So this slide shows the blue part of the circle shows those times when we were able to get in and connect with the person with 1 to 2 business days which is, again, we were allowed them to have warm handoffs, collaborate on discharge planning with the social worker, and as I'll show you in the next slide, we have better outcomes. So this slide really speaks volumes to the work that this initiative has done. If we look at this slide, the blue is on the left side shows the number of emergency department visits, and then the orange part of the slide demonstrates the same period of time. Focusing on the middle would be the 90 days before intake and 90 days after intake. So you can see after that rapid access to case management intake, emergency department visits went down 51%, and the number of hospitalizations, admissions went down 77%. So we think that's a really positive impact that we've had. Again, this is just data from North Memorial, so it doesn't look as if there was hospitalizations at other healthcare systems, but we still think that that's a pretty promising outcome. So the next phase or next arm of our model was to develop a care navigation program, as the clinic care coordinators had identified the need for somebody to be able to move more outside of the clinic. And so we hired a behavioral health care navigator with some additional grant funds to start that process for providing some short-term collaboration and navigation, some that would have a strong emphasis on referrals and housing support, and then work collaboratively with the mental health and addiction clinic at North Memorial Health, the community paramedics, and the emergency department. What's unique about this is that we were able to provide, North Memorial Health was able to provide a drop-down workspace in their mental health and addiction clinic. So the primary care navigator has space there and is able to really make those connections and relationships, and it's super available to people. While they're really housed, kind of employed at Vail Place, and that's where their primary office is, he spends a lot of time up there and is able to, as I said, make those relationships with partners. We thought we would be able to sufficiently manage the care navigation program with just one person, and we have needed to supplement with MSW interns, which has been a great opportunity for them to really see this innovation as we're fleshing it out. Okay, so, sorry, lost my place for a minute on my slide. This slide demonstrates some of the different the Total Care Collaborative interventions, and it also blends in some of the other interventions that North Memorial Health was working with at the time when this slide was put together. But it's, as you can see kind of by the shaded orange, those are the programs that we've done. And then North has also done some additional high ED utilizer and primary care coordination care conferences. And then also that last line, or that last section, is really about how are things improved. So we've really found this to be helpful to look at how we can improve communication and connections. I mentioned the interdisciplinary cross-sector team conference. This is our last model, and this, as I said, was the Rising Risk Conference. Here are just some key things to think about before you would start a program like this. You want to make sure that everybody kind of has an idea of how this care conference, team conference might work. It's really important to outline this and to identify those key components. So the Rising Risk Conference, again, it allowed us to really start testing this cross-sector multidisciplinary team process, and again, working really on that IHP population, the Medicaid population, and individuals who were engaged with the IHP as serious mental illness and complex care needs. We worked with 3 different clinics, Brooklyn Center, Brooklyn Park, and the University of Minnesota Broadway Family Medicine Clinic, and we looked at 3 or more ED visits in a year. And we've used a hotspotting method, which is a data-driven process to identify extreme patterns in a defined region of the healthcare system. And we really had to just keep drilling down this data. When we first put that into the, I believe they used Optum at North to kind of help us identify this target list. But it really took us a while to kind of get there. It's not a simple process, but once we have our list, which is utilized regularly for us to have the care coordinator vet to the care conference who are those individuals that they could use some support in talking with and making referrals and identifying interventions. This slide shows a variety of partners that join into those rising risk meetings. We're certainly open to other people joining, and we meet about twice a month for 90 minutes. And we are, I think the biggest challenge with this has been identifying processes for tracking, since not everybody has the same access to Epic. But we're continuing to have conversations and working out kind of the nitty-gritty details. At the rising risk meetings, we review the items on the left and other factors, and then on the right, we talk about a variety of interventions. And this is not a comprehensive list, but it's really great. We've had some wonderful success stories of people working with the clinic care coordinator, with the community paramedic, with the care navigator, the chronic clinic, the people that are going into the ED. We've had just really wonderful collaboration and have had some great successes. This next slide is probably difficult to see, and really what's in the content isn't as important as what kind of just knowing that you have, how important it is to have a process for, what's your vetting process, who's at your care conference, what are your intervention options, and that sort of thing. Some of our strengths and successes. The next slide. We believe that we've had an impact at breaking the stigma barrier of mental illness in a healthcare setting. We've built energy and excitement, and we really value being an equal partner at the healthcare table. Another success for us was our access to Epic and our outcomes. And then lastly, I'd like to close with our sustainability planning. We're working on that now. Our grant ends at the end of this month, and we want to be able to continue our focus on, the integrated health partnership population as well as others, our direct engagement with the health systems, and we have developed a behavioral health home and are newly certified. I think that that's another avenue that we can add to the service mix. So again, we're working towards value-based payment model discussions and are looking forward to our future. Thank you.
Thank you very much, Shelly. We're going to go directly into Jan. I do want to invite people to go ahead and use the chat. We will have, I think, some good time for questions. And if you do have questions, go ahead and put that into the chat box. And after Jan's presentation, we'll open it up both by phone as well as access to questions in the chat. So, Jan, do you want to go ahead and
Sure.
start?
Okay, thank you. So thanks for listening to us today. It would be more fun if we could see you in person, but we'll do that. At least the two presenters are in the same room together. Just to give you a little background, so just to add a little levity here, if you hear an accent, I'll tell you that I can speak Minnesotan, and I also can speak Canadian. So I live 10 miles from the Canadian border, so sometimes people will ask where I'm from because I sound Canadian. I only know a few words in Canadian, and that is toque for a hat, and you phone somebody instead of call somebody, and a instead of, in Minnesota, I might say oofta. So just to give you a little background, I'm from Roseau, Minnesota, which is a small little town of about 2,700 people. It's the county seat to Roseau County, which is about 16,000 residents in our county. I have worked for LifeCare Medical Center for 27 years and in a variety of jobs. Starting in 2002, started as a behavioral health therapist, as the only therapist, and as time has gone on, we've created more of an outpatient department. So LifeCare Medical Center is a critical access hospital. We have a non-LifeCare clinic that's on the same campus as us. And I'll make reference to that a little bit further, how that is different. So we started our behavioral health program in 2002 with me as the only therapist. We now have 6 therapists. And I just was making a note here when Shelly was talking that when we started doing behavioral health as an outpatient department, in my mind, it was we would see patients and do therapy. And quickly you start realizing how much more there is involved in that. And that has led then to some of the things we're doing now to be much more integrative in behavioral health. Just to give you another little idea, we are 60 miles from the nearest inpatient hospital. So if people need a psychiatric admission, the closest one is 60 miles away. Oftentimes there are no openings, and that's not unique to us. That's the way it is these days in Minnesota and many other states. And then the other challenge is if there are openings, oftentimes we cannot get somebody admitted for other reasons, such as their medical condition is too acute, or they have aggressions that are not conducive to be admitted to the hospital, or legal issues that will prevent them from being admitted. And that's not so much in the state of Minnesota, but we are also fairly close to the North Dakota border, and so we will use inpatient facilities in both Grand Forks and Fargo, but if you're crossing state lines, that can be a challenge if they're on probation or have some other kind of legal issue. So anyway, the first slide here shows that we were awarded an integrative behavioral health mentoring grant through the Rural Health Innovations, which has been very good for us. It's really kind of pushed us to move forward, but to say prior to that, we were already doing some things that were quite integrative, such as we had started what I call a roving therapist concept. And people think, oh, the therapist is running all over the county. Well, that's not exactly what it is. It means that we have really tried to address situations outside of our hospital walls that come up. So if the school has a situation that seems urgent, or if the jail has an urgent situation, or if there's an urgent situation in the clinic that's on our campus, we are trying to respond to those as quickly as possible, hopefully the same day. And so maybe roving isn't the greatest way to describe it, but it gets people realizing that we're going beyond walls of having somebody come in for an outpatient mental health session. Also, we do have a crisis response program in place in our county that's provided by another entity. So it's not LifeCare providing the crisis response, but we work very closely with them. Okay, next slide. So the objectives that we identified in this grant that we were working on was staff awareness and training, and we decided we needed to start right within our own walls. It was very interesting because my perspective would be that emergency room nurses would be quite comfortable with mental health things that might come through the doors, and it was very interesting to find out how uncomfortable emergency room staff were with the mental health, behavioral health crisis that would come through the door. So that was very interesting. When we offered our first mental health first aid class, the emergency room nurses were clamoring to have that training. And so that is something that it was a real takeaway for us and something that is in our ongoing plans for training, that you need to specifically train emergency room staff for mental health first aid, and then to move it out into the community. So just kind of a sideline, we thought it would be interesting to find out how best do people like to get information. So we did our own little survey within our system to find out how employees these days want to get information. We decided probably pretty quickly that reading a newspaper wasn't going to cut it. Radio ads probably weren't going to do it. We need to be more involved in the social media, texting, Facebook, those types of things. And I know there's all kinds of issues with social media, but, if you can use it for the good, it really does disseminate information pretty quickly. So we can use that for some of our future marketing strategies. And then moving on to providing training to key community groups on mental illness, signs and symptoms, and resources available. And so that's an ongoing thing that we're doing. And it's something that we really realize that it's not a once and done because staff members change, and we were really promoting this out into the community members, so that say a supervisor at Polaris Industries, which Roseau is the home of Polaris Industries, if the supervisors get the training, while that supervisor moves on, there's a new supervisor. So we need to keep doing this. Okay, next slide is, so determining where the best practice for first point of access was one of our things. And so we looked at our community. We brought people together and we looked at who are these folks. So we have a couple industries. We have Polaris Industries. We have Marvin Windows. Those are our two big industries in our community. And so those are people we're reaching out to, in addition to teachers, law enforcement, clergy, to offer the first aid, mental health first aid training. And just a little story about offering that to our clergy, because that was one of our first groups that we offered it to. And when they were done, they were asking for a pamphlet of how they could we want a pamphlet so we know who to call when we need something. And so it came back to me as the director of behavioral health. They said, our clergy in our community want a pamphlet. And I'm like, a pamphlet for what? And who to call, when do we call? And I just kind of sighed, thinking, oh, it's a little bit bigger than a pamphlet. So I said, well, how about if I meet with the clergy? It's the ministerial. And we have, in our county, we have 3 different ministerial groups in the different areas of the county. And so I offered to meet with them, and they came together, and we just had this fabulous conversation. There was no agenda, just sat down and listened to them, and I asked them the question. I said, what scares you? What person walking through your door on Monday morning in your office, in your church, or wherever it is, scares you? And they just had great stories about people, and you just think about it, that makes so much sense, that people go to the church. It's free, first of all. Ministers are good listeners, and they're very open and inviting to people. But the clergy talked about how they just feel very overwhelmed about people's sad stories that they hear and not knowing where to refer them. And so it was just really an interesting discussion about what happens in our community. And that was kind of our first takeaway, that you can talk about mental health first aid and symptoms, but if you don't know who to call when that person walks through the door, you're not probably going to be very good for them. And so we talked about our specific community and who do you call in our community, and actually giving them a name. And, if that person that they get a hold of maybe doesn't have all the answers for them, but they know how to connect them with the right people. Next slide. So our grant was all about integrating behavioral health and really a focus on primary care. But in our community, LifeCare doesn't have primary care, so that clinic. So it kind of forced us to look at the community integration. And so I saw one of the advantages to this is that it's not a silo into only the medical world, but really it forced us to collaborate with the non-medical agencies. So those things such as our local jail, our schools, our court, and our judge, who is just extremely innovative in her thinking, and she's always looking for a way to find a better solution for the people that come before her. Our Department of Corrections, which over the years we've developed quite a relationship, and our little outpatient behavioral health agency does all kinds of groups for our Department of Correction and our courts, such as we do the domestic violence groups. It's the 20 to 25 week group, and these are all people that are going through the court system, and they're getting their anger management, cognitive behavioral issues getting addressed through that way. And then, of course, a big player is our relationship with our County Social Service Center. Next slide. So this led to the idea of a community care team, and we had already been doing some work with our community members looking at the data-driven justice initiative model that looked at how many people are super users in our jails and frequent flyers in our emergency room. And oftentimes they're the same population of people. And so we were really interested in finding out how many of these people are the same people. And so we really strengthened our relationship with our local jail, and now we are in the process of starting what we call a pre-release team at our county jail. And then that becomes our focus for our community care team. And you see on this slide, I hope you can see it, the people that are sitting on this team, and this team is just getting going, but it involves the jail manager, the sheriff, somebody from Department of Corrections, both the financial worker and social workers from our county social services, our public health nurse, because our public health nurse is the medical person that goes into the jail, a mental health professional, in this case, they're again that roving therapist, a county attorney representative, the community action people, because we discovered that they are really vital because they hold some of the transition dollars. So when people get released from jail, if they don't have housing or transportation, they're the person that oftentimes comes in and helps them figure that out. And then we're hoping at some point to have a community health worker that can also work in conjunction maybe with that community action representative to follow them after they've been released. Next slide. So the idea here is that the person being released from jail would actually have a community care team and a community care plan. And so a lot of the things that go into that care plan is medical follow-up that's needed. Do they actually have a primary care provider? The whole idea, if they do, the whole idea is to reduce emergency department visits. What are their financial, their housing, their employment, their transportation needs? What are their mental health and behavioral health needs? Do they need to be referred for community-based services? Do they have a chronic and persistent mental illness? Or if not a chronic one, do they need to be referred for behavioral health for a good assessment? Do they need to be on medication? And then application for assistance. We find that a lot of people that are in jail do not have any health care insurance. So even though maybe they're seen while they're in the jail, maybe the public health nurse is following them, maybe they've been to the clinic or to the emergency room and they've come out with prescriptions for medications for whatever. Maybe it's for depression. depression or anxiety, but maybe it's also for diabetes or hypertension or whatever other condition they might have. If they don't have access to get the medications when they leave, the work that's been done when they're in the jail kind of falls apart afterwards. So that's a huge focus. The next slide talks about the community health worker, and this is something that we are interested in doing, where that community health worker should sit. We haven't quite figured that out. Should it be part of the emergency department? Should it be part of public health? Should it be part of the behavioral health department? But certainly one of the parts that it would be using then is to increase the appropriate utilization for those people that are getting out of jail to hopefully keep them from coming back to jail and from the multiple visits in the emergency room. Next slide. And you can keep going there. Okay, let's find that slide. Okay, so we have been doing some data collecting, and that was one of the things that this grant required, and so we did some looking back. So we started tracking the mental health, behavioral health visits that came to the emergency room, and we went back as far as October 1st of 2014, and then our last gathering has been the second quarter of 2017, and we are seeing a reduction in emergency room visits, especially the further we've gotten, so into 2017. So by using the roving therapist, we've really been able to see those people sooner, with the whole idea that we see them further upstream so that they don't have to go to the emergency room. And the other thing that has been especially, we think, a positive is being able to reduce the transfers from the emergency room either back to jail or into their inpatient psychiatric stays. So that shows us that using the roving therapist or using more of an open access concept for the urgent issues in our outpatient behavioral health department is reducing those transfers to inpatient or reducing a number of visits to the emergency room altogether. Next slide. We started using the roving therapist concept in the jail back in January of 2016, and to this point, those inmates that are seen by the roving therapist, we have not had any inpatient transfers, which we think is a huge success. First of all, if you can avoid an inpatient admission, it's certainly a lot cheaper. We think that it's better for the patient. Anytime you have to go to an inpatient psychiatric facility, that is considered a pretty significant event, and if we can address their needs on an outpatient basis, we think that's overall better for the person. The next slide. Okay, are we to the video? Okay, we can. So, the Minnesota Hospital Association created a video focusing on our small community and the collaborative effort we've been able to do. So it's just a 2.5-minute video, and hopefully you'll find it interesting, and you'll see some of the people. You'll see the roving therapist, you'll see the chief of police, you'll see the school social worker. So I hope you'll enjoy it, and hopefully we get it to go.
In the past 6 years, we've seen a large increase in depression and anxiety in both our students and our staff.
Mental health care is in a bit present in the nation, the rest of the county. What we have is we have credited for being such a really or a crisis that comes to the ER, or for me to have to go to Vail to see a person, or to have a person come into our offices.
If it obvious to us, then we could have people who you see at the time of their urgent situation or the emergency situation by a professional, we can avoid a greater crisis. Because we are a small town, people know each other. And they have issues with going to a mental health provider that they might know, or that they go to the same church with, or that their child plays hockey with.
Folks have small, close-knit circles of friends and family, and that can often inhibit them sharing with others what they're maybe going through or struggling with.
But having a roving therapist, they're able to see the person right away and to make an assessment of them. LifeCare will actually send the therapist over to the jail to see the inmate and visit with the parent.
We're a large county. It can take an hour of your time to get to our office. If you're at one of the outlying areas of the county, barriers are to have an infant ER from psychiatrists or possibly psychologists. However, LifeCare has done a fantastic job of helping to decrease that barrier by doing telemed and the services that are available for our students. I believe the roving therapist program has improved the lives of the people in our community.
LifeCare is absolutely a wonderful community partner. They want to hear from us how we might better work together and community to enhance patient care and care of our community.
I think we are helping the overall mental health of our community, our county, by the collaborative work that we're doing. Getting outside of LifeCare's walls, looking at the jails, with our law enforcement, with our schools, they need to know what kind of services we have to offer. And then we want to work with them.
Well, let's go back to, thank you very much, Jan. That was really terrific. And I have to say, hearing both of these stories, I'm just struck by how thoughtful and effective this has been to really be able to address some of the really critical needs, and that you're both starting to see some really promising results in terms of lowering ED visits and really just getting patients better care. So I think it certainly is very promising. It's really wonderful to hear about this. I'm struck by the fact that there are two very different projects and different approaches. They've got some similarities. Certainly what I was hearing was some real attention around how do you first get patients addressed and into services immediately as possible, because I think in both cases having access quickly to those services has really been a key component that you've really both focused on. The other things that I was hearing about was that you're both developing a deeper support for how do you help patients really navigate the broader resources, and how do you help connect them into things that maybe have not been traditionally resources that are brought into healthcare, housing and transportation, some of those things. But really seeing some very good results. I do want to open this up for others. We included some questions here that we could certainly get started on, but just reminding people that if you have questions that you want to ask Shelly or Jan, please do put them in chat. And actually, let me just even refer to the phone now, if we could open up the phone lines. And if there are people who ask the questions now, really want to make sure that we have time for that. So let's open the phone line and see if there's questions. Otherwise, as I said, we'll focus on some of the questions that we've added to the slide deck.
And the phone line is open. If you'd like to ask a question, you can press star then 1 on your phone. And I'm waiting for questions.
While people are queuing up, maybe what we can do is use the time. The first question that I had is both Vail Place and LifeCare are obviously innovative behavioral health providers.
You guys have done a lot of very good, thoughtful work and have really created some good approaches. But I'm interested, what was the initial catalyst? Like, how did you as a behavioral health provider initially start reaching out and working with the medical providers? Did they reach out to you? Did you reach out to them? How did your programs get started?
This is Shelly, and I can kick it off. I think Vail Place was very intentional about our goal of trying to make our kind of our whole health model and our recovery-focused model to really kind of expand that and really make sure that we were working with people to address their primary and their specialty care needs as well. So we had this vision for the future. One of the things that we did was selected intentionally board members who could bring us some knowledge about healthcare systems, maybe people who were connected to the healthcare system. And we actually had a board member who worked for North Memorial Healthcare at the time. And he made some initial introductions, and I want to say those initial introductions occurred about 5 years ago. But it was really kind of an opening and for us to kind of get in and start having conversations. Our board also was able to really help us, those who were affiliated with healthcare were able to help us identify kind of some of the basic things that now we know so well, which is what do we have to offer, and what we have to offer are those things that I mentioned in my slides, addressing the social determinants of health and the things that is hard for healthcare to address behind their healthcare walls. So I think it was just that it started with one or two conversations, and it just built and built from there.
I think the catalyst for working with the medical providers is that most medical providers feel pretty inadequate when it comes to whether it's mental health or some of the social determinants of health. They don't have the time. If you look at the statistics for how long a clinic visit is for a physician with their patient. And so I think what we did, first of all, is let the physicians know that we wanted to help them. So, give us a call. And I think one of my mantras has been, we try to look for a way to say yes to somebody that makes a request to us. Even if we're thinking this is not my problem today, still to go to them and listen to what the situation is, because oftentimes maybe it's pretty simple, and maybe it's not a simple problem, but the solution that day might be pretty simple, and I got it off the top of my head, where the physician or the nurses that are working with them don't know that phone number, don't know that agency to call. So being willing to show up, I think, has been a huge advantage, and the providers trust you so that they know they can call you up and that you'll come and you'll listen to the story, and maybe it's something that I'm not in the end going to do something with, but I can kind of take it off their hands, and I think that really builds trust. And then, I think that's the biggest catalyst.
Very interesting. Let me actually go into the next question, because I think it really builds off of there. So, many of the people on the phone are part of medical communities, and if they're looking for building a relationship with behavioral health providers that could develop into a relationship like that, do you have any thoughts about how do you develop those kind of relationships? How do you find a good behavioral health provider that might be willing to engage with you in a creative way?
This is Shelly again, and I would say that really the primary way, I think, is to just start having conversations with people, to put yourself in situations and settings where you might have the opportunity to talk with behavioral health providers. I think it's really important to know that not all behavioral health providers are created equally. Not everybody is willing to think outside the box. They're not willing to consider changing processes. They kind of have their routine and how they want to do things. So you really have to look for organizations that are willing to be, as I mentioned earlier, really creative, are able to look at the world in a different way. I would say if you're having conversations with somebody and you're not finding that to be the case, then you may need to take a step back and talk to some other providers. So it might be something like attending some behavioral health conferences in your local area, making kind of those initial connections, finding out who to talk to.
I definitely agree. The conversations and the comment about not all behavioral health providers are created equal, that is for sure. You have some that have much more of that clinical diagnostic bend, and then you have others that are much more problem solving. And oftentimes I see the difference between a psychologist and some of the other therapists. So if you get somebody that's come up through the social work ranks, they oftentimes have much more that problem-solving hat on, as well as the diagnostic and the therapeutic. And that's good. That's what makes a good team. If you have both of those types of people working in the same agency, then you have a really good blend. But I think in today's world, it's all about collaboration, whether it's your medical home or your behavioral health home or your community behavioral health home. I mean, everybody has recognized that there has to be a group. It's a group work. It's collaborative work. It's the warm handoffs that Shelly, you've talked about. You can't just give a patient a card or a phone number. That just is not going to work. Our system is so complex these days that it really takes a professional coordinator to get these people the best service they need. I had somebody just the other day say something about medication. Why doesn't the person just take their medication? And I said, well, you look at anybody, whether they have a mental health need or not. How many people are truly good about taking their medications the way they're prescribed? People self-medicate, they stop medicating. Well, that might be people that are on one medication. You take somebody that's taking many different medications, or they've got many different providers involved with them. Your chance of them following all of the plans just are not very good. So really the collaboration and relationships and trusting the different people that you're working with is really critical.
Let's open up. Actually, I see that there is actually a question that's come in. Was connecting with primary care part of either collaboration? And if so, what was that experience like?
This is Shelly, and yes, connecting with primary care was part of our collaboration. Our goal was to create these different care models, and we can't really do that without connecting with, the primary care providers. I think it's really expanded as we've gone along, and initially as I said, with the rapid access to case management, that really came initially from the inpatient unit, but then also through the partial hospital program. But certainly for the rising risk group as well as care navigation, those have really been fed through primary care.
The connection with the primary provider is critical. As much communicating back with them as it was initially getting a referral from them. So, letting them know what's continuing to go on with a particular person. And Shelly, you talked about EPIC and getting access. We're in the EPIC world as well. And so there's some great tools to use just within the electronic medical record to stay connected so that the next time that person sees their primary care provider, they can see what's actually been happening with them in other areas.
Yeah. And
This is Shelly again, and I think that one of the key things for us was granting that what we have what's called Epic Care Link, which is view only. And I think as these partnerships develop and expand, it's really critical that we are able to have full access so that we can, instead of writing a note and sending it to a care coordinator who then copies and pastes and drops it in the record and then we put it in our system, that we have a way for us that we can document the work that we're doing so that when someone shows up at the ED, they can go, oh, they're connected with the care navigator or they're connected with the case management program. It saves time because it allows them to really be able to see what's happening, and I think that's really critical.
Good. Let's see, another question that came in is, how do you make sure that there's a roving therapist available to respond quickly to an urgent issue at any time and at any location? Same question for the people who go to hospitals for the rapid case management program. Are there therapists, rapid case management responders in multiple roles at the organization?
Should I do the roving therapist first? Okay, so with the roving therapist, this is not a 24/7 position. So if somebody has an emergent situation, then the crisis response people are activated, and, oftentimes in our community that person ends up in the emergency room, and that's pretty typical with crisis response programs in the greater Minnesota, is that they are coming to the emergency room more than they're being seen anyplace else. So if something is emergent and it's happening what I would call after hours, the crisis response team is seeing them first, and then oftentimes they will make a referral. So the roving therapist may actually pick up on it the next day. But what we've found is by that relationship being built between the roving therapist and the jail or the school or somebody else, they will do a consultation. We're doing more consultations than actually seeing people directly, because the school social worker might call up and say, I want to run something past you. And oftentimes the school social worker is handling the situation, and then it can be more of a routine appointment that's made in behavioral health. But if not, then that roving therapist will say, okay, my schedule's open this afternoon, I'll see them. Or maybe it's later in the day, and we'll say, okay, can it wait till tomorrow morning? And if so, come in at this time. But if it's an emergent situation, then always it goes to crisis response or to our emergency room.
Well, and regarding the rapid access to case management, I first want to just a little bit of background, but initially we had, when this team was developed, it was a very small team, and now it's one of our 3 case management teams at Vail Place, and it is by far the largest and for the most people. The demand has been that great. We have each case manager on that team has a 4-hour window that rotates on the calendar. So every day somebody is available to go and take that appointment that if we get a call from the hospital or we get the referral packet from the hospital. I think this is one of the things that, with the grant we were able to do the planning and implementation, but we weren't able to, build in any funds for kind of how do we, provide for this service. So it's something that's been a little bit of a challenge for us and for the case managers. They have to work really hard to manage their caseload, which is the same as everybody else's, but still have that window that maybe every 4 or 5 days they're available. They may not be able to go that day. There are crises that come up and things that happen, but they're also typically in a secure setting, and so our goal is same day, next day. So if they can't get to it one day, then their colleague will go the next day or they'll go the next day.
I could make a comment on something that I found pretty interesting, is this having a therapist with basically an open day, and you wonder how in the world is that going to work for budget or productivity. It's really interesting because her productivity is right up there with everybody else in our department, even though her calendar, her schedule is pretty open. So you know, if you're looking at it from a budgetary standpoint, having that open access, I think is from a budget standpoint pretty spot on with the other therapists.
It's really interesting. Let's open it up. I want to make sure if anybody is on the phone and wanted to pick up the phone and ask a question, that you had an opportunity to do that. Are there anybody in the queue on the phone?
At this time, I have nobody in the question queue for the phone.
Okay, thank you.
Mm-hmm.
Well, got a couple more questions, and as long as we've got a little bit more time, let's put some of these questions to Shelly and Jan as well. Did your collaboration start first with specific services and evolve? And certainly you've got a lot of things that you're doing, and I would say there's a robustness to that. It seems as though it's pretty spot on for very kind of targeted and focused ways that you're working with patients. But did you create that over time, or did you start out with developing a more comprehensive approach and actually implement it more broadly and in that way, or did it start small and evolve into a bigger and more complex program?
Should I go first?
Sure.
Well, I guess I see behavioral health in Roseau County has been collaborative since 2002, just because necessity required that. But definitely when we went into this grant, it became more comprehensive and more specific in the fact that we identified how badly people needed to have that mental health first aid training. That was really an eye-opener for us, that I said it right away, how we assumed people had that information, had that knowledge, and that was really an eye-opener to realize that they didn't and how much that was needed. So that, when we identified that, then our approach became more comprehensive.
And our approach, really started out with kind of the one component of the rapid access to case management. But as we went, we continued to add additional ways to reach this population. So we started having the community paramedics coming into Vail Place and in the clubhouse community support program and engaging with them and, taking vitals and doing some education with them on their health conditions and that sort of thing. So we continued to, again, through collaborative measures, kind of grow our programs. And we did kind of phase things in as we kind of saw the need along the way and as things started flushing out and the relationships developed and more conversations occurred. As I mentioned, really the kind of the need for the care coordinator really came from the clinics and the clinic care coordinators, that they were just feeling kind of lost, like, what do we do? There's only so much we can do in the clinic. And so that kind of followed, and then kind of our last effort, kind of our last opportunity then was through the rising risk. And that one was is still getting up and going. We really don't have a lot of outcomes yet, but for that, but I certainly can say that start with one thing. Pick one problem. Maybe do some fish boning or some problem solving, and what's the question we want to address, and then work out from there. And I think what you'll find is, wow, this one question is really this issue or concern is really big enough that we can start with that. And I think really you'll be surprised if there's other things that you can do or other ways that you can have an impact.
The last question that we have on the next slide actually goes back to some of the discussions that we had in prep for this webinar today. And I know that you both had some feelings about the credential of some of the staff that you're working with and the impact on the ability to be able to address needs quicker in the ER or kind of rapidly. And wanted to give you an opportunity to talk about that and ask the broader question if there are other program components that you might think of that really, if someone is looking to try to reduce ED visits, are there other things that you might give advice that would be useful program components that would be helpful?
I think it's really important to make sure that you have at least one, licensed mental health professional on board to kind of help provide the supervision and the consultation. A lot of these issues that come up for people are pretty challenging, and I think that, for example, our interns are all supervised by a mental health professional, because it's tricky, and when you're out and kind of doing that mobile work, to have kind of a sounding board and a connection to really talk through that, I think is really critical. I think some of the work that, LifeCare has talked about, like the community health worker and that sort of thing. I think there's great opportunities for community health workers, peer support specialists to engage in a lot of the work that we're doing, but again, you really need that support system for them as they are out and about.
Yeah, I agree. The thing that we've identified is that, and we made reference to that in the video, is that if a professional can see and touch the person, and that doesn't have to, I'm all for telemedicine, but if the professional sees the person directly, I think there's a greater chance that person in the emergency room will not have to be transferred to an inpatient setting. If it's something less than that and they're consulting with the professional, but the professional doesn't actually see the person, there's a lot of times the default is we better put them in an inpatient setting because everybody's scared of the liability. Is this person going to harm themselves if we don't admit them to an inpatient setting? Where if the professional actually sees the person and can use their clinical judgment face-to-face with the person, there's a better chance that you can avoid that inpatient stay. And so it can be really difficult to always have a professional available, but boy, if you can, that makes a huge difference.
Terrific. Well, thank you. I'm going to take one more look and see if there's any other questions coming in. I don't see anything. Thank you all for those of you who have hung with us for this kind of lengthy webinar, but I think it's really been really terrific information that come from both Shelly and Jan. Their contact information is listed here. Do let me know if there's anything else that you would like to learn about with this. But thank you all. Terrific presentation today, and I appreciate your time this afternoon, and we'll give you 5 minutes back to your afternoon. So thank you all.